we're in this unusual moment now with the pandemic. And there's been quite a bit written about the fact that clinical trials are being put on hold. And it makes sense, of course. You've got a toxicity profile that you're not quite sure how to incorporate. So it makes sense from a drug development perspective, and then bringing patients into clinic for their surveillance, and it is in their best interest or not. But I am curious to what extent the pandemic has altered the care of your patients. And is it something that, has it changed even the prescribing patterns where an oral agent is preferred because you can do telemedicine with them, or changing the rate, the frequency with which you monitor them? How often are they coming in? And really, because of blood work and the physical exam is not that critical. But if you could speak to the pandemic and its impact in management of breast cancer patients, I think would be helpful for the audience.
Yeah, I would just make a couple of broad comments at the outset. One is, I guess, sort of we separated into those with early stage disease and then obviously metastatic disease. And what most centers have experienced, particularly where there's a significant COVID activity, is that screening has been stopped, elective surgeries have been delayed, patients who are going to get surgery have been put off. So in those circumstances, particularly where somebody has an early stage breast cancer who's ER positive, who didn't get surgery, we may start them on endocrine therapy instead of giving them chemotherapy. For the patients who are triple negative, who have HER2 positive disease, we have been treating them. We continue to treat them. But, the surgery issue and radiation, they've been pushing back too and delaying things. With respect to metastatic disease, if patients are on treatment, they continue treatment. If patients are starting treatment and we have an option of using something less toxic, I think we would prefer that, particularly in older patients, where we can do everything we can to keep them away from the hospital and certainly out of the hospital as an inpatient. That would be the desired thing. So with respect to the topic today,
institutionally, I don't know if this has been reported or studied, but certainly nationally, all across, cancer screening procedures are down, mammograms are down. Are you concerned about both the patient with palpable disease as well as the patients not getting screening mammography, that there's going to be a surge of more advanced stage patients coming into clinic at some point in time as lockdowns lessen and people's fear of the hospital reduces?
Well, we think there's going to be a significant uptick in the summer as screening comes back online. The example you gave of somebody with a palpable lesion, those are patients that we're going to start evaluating and working up. And if they required some form of therapy, even if it's preoperative endocrine therapy, we would start that. But with respect to unknown cases that exist in that screening pool that we're not even evaluating, we're not hopefully going to be pushing them off for more than a couple of months. But it's possible somebody could have aggressive disease in that group and get worse over that period of time. We're starting to open up a little bit with screening, just starting in the next week or so. But that's already 2 months of screening that hasn't been done in a very large center. So there's a large population of breast cancer that exists in there. And, we're going to be busy once the ORs start opening up again.
And Steve, you've got not only a large population, but you've got a hotspot that significantly impacts that population. Are you able to model what you think is going to be happening and how to in any way prepare or plan for that?
The short answer is no. Return to care is happening. Actually listening to the radio this morning, and one of our leading oncologists here in New Jersey was talking about return to care for his system with cancer care. Women with breast cancer who have been anxiously waiting for her surgery, it's beginning to happen. I was talking to a leader in GI oncology, and he was saying, we've seen this trend downward in colon cancer for, I don't know, the better part of a decade, Bill or Joyce, maybe Bruce, longer than that, and his concern that with the lack of screening, that's going to have a negative consequence on that particular type of cancer. Mammography was mentioned earlier. So we don't have any thing yet. I mean, we've just been kind of making our way through the crisis and making policy changes to allow for telephone in addition to synchronous audio and video. Certainly the oncology community, like the ID community, like the primary care community, like the dermatologists have embraced telehealth. So that's been a big factor to provide some level of longitudinal care, although certainly, again, it doesn't allow for the woman with breast cancer to get her surgery, which is, again, as I said, is just beginning to, as we start to see things around return to work, what health systems call return to care.